There are lots of non-opioid medications to use. I'll review them very quickly, but NSAIDs and COX-2s, depending on renal function and cardiovascular condition, ibuprofen-like medications affect prostaglandin levels. They work mostly at the peripherally. They don't have cerebral side effects. I had a patient who was dependent on methadone, got off his methadone, went through treatment, 2 months later had dental surgery and called me up and he said, "Doc, what do I do about the pain?" I said, "Well, check with your dentist, but if you don't have a bleeding problem, you could probably take ibuprofen 800 milligrams every 4 to 6 hours." He called me back the next day and he said, "Doc, the only thing that thing did, that Motrin did, was took the pain away." Then he realized what he had said. So we actually reframe the experience of pain and pain relief. Because if pain relief means opiate effect, people will be vastly disappointed compared to, oh, it doesn't throb quite so much in my back. Tricyclics, amitriptyline, nortriptyline, doxepin affect the serotonin system. As you know, they're sedating, so for people who have insomnia, which is a common accompaniment of chronic pain, they're helpful. They are dry, they're anticholinergic, so they cause dry mouth, and they cause sedation in a number of people. SNRIs, newer antidepressant, we're talking about serotonin, norepinephrine, so we're going to enhance that inhibitory tract that we all have with duloxetine or Cymbalta, Savella, Pristiq, I can't tell you the generics for those, and venlafaxine is the oldest SNRI. I think if chronic central pain, which is what I was talking about earlier, is present, they're worth a trial. Anticonvulsants, particularly helpful for neuropathic pain, but also for central pain. Gabapentin, Neurontin, pregabalin, Lyrica. Topamax topiramate is good for headaches particularly, and Motrigine, Lyrica, Lamictal are all helpful to some extent for some people. And you know, the principle of pain treatment is some things work for some people some of the time, and then sometimes they stop working. So you really have to be fast on your feet if you're going to be treating people with this condition. Muscle relaxants, anyone but Soma. This is the sixth take-home of the day. Soma, bad drug, bad drug. Soma's carazoprodol turns into meprobamate. It's a sedative. It's a bad drug. It's off the market in Europe. The European Union has banned it from being prescribed. In the United States, for some ungodly reason, it's not even scheduled, and I can't tell you why.
It's a controlled substance in Nevada.
It's controlled, but it's not scheduled. It's scheduled, you know, right? So it's Schedule 4, right? It's not as scheduled.
No, they don't have a schedule for it, but it is. They do consider it a controlled substance, and you have to keep separate records for it and everything, just like you do the 2 through 5.
In a pharmacist.
Yes.
Yeah. But we all know. Do you know that it's the 3rd most commonly prescribed drug in the state of Nevada? My friend Laura's here. Her mom's 90-something years old. She went to the urgent care, not in our state, and got a prescription for 60 Soma because she had muscle spasms. She went home, took a couple, and really ended up in trouble. So Soma's a bad drug. There are other muscle relaxants. If you think muscle spasm is in play, Robaxin or methocarbamol, Scalaxin is tizanidine, is that right? No, tizanidine is Anaflex. And Leorisol, baclofen, all safe, non-addicting. Soma is very dependence-inducing. In Vegas, the cocktail, Las Vegas cocktail, is hydrocodone Soma. And what the kids are after is Soma coma. So I gave this talk to some docs, and there was a doctor who was very offended by this. He said, Soma's the best drug. I always prescribe it. You know, kind of like, you don't know what you're talking about. And I said, well, what's the evidence base for your choice to use Soma? He said, well, that's the one the patient asked for. So, topicals. How many people use topicals for chronic pain in practice? Good. You know, they're amazing. Sometimes they work when they shouldn't even work. But lidocaine comes in a patch form. Anti-inflammatories come in patches, Flector or diclofenac patches. We compounded gel had the pharmacist compound with 6% ibuprofen, 6% lidocaine, and 6% gabapentin. We use it for inflammatory, but also neuropathic pain, and sometimes even central pain. I don't know if it's a placebo effect of just putting something on, but it really causes improvement. Capsaicin is a chili extract that's now available in a patch. I can't remember what the name is. Do you know? Solanoprost, yeah, that's right. I actually had an experience with capsaicin. I went to physical therapy for my back pain. Did I tell you that I had back pain? And they did a whole bunch of stuff to me. They used to stretch me and do this manipulation, and they'd use this special cream. And I didn't know anything about the special cream. And one day they gave me a massage, and I was on the table for a long time, and I left the building, and I got into my car. It was 112, a typical day in Las Vegas, and I sat in the car, and within like 5 minutes, I just got this incredible burning sensation that went down my leg, and I'm like, I'm paralyzed, you know? And I called the physical therapist, and I said, there's this burning. Oh yeah, we have capsaicin in our cream. It's like, well, you really ought to tell your patients that, and capsaicin is activated by heat, so it's not uncommon to put the patch on and then